Today's about sepsis. I'm John Parker. I'm one of the intensive care consultants based at Leicester Royal. And I've been involved with the leadership and management around sepsis for about the past 10 years or so. There's been a few changes of late that I'd like to bring people's attention to. This is also an opportunity to go through some of the sort of fundamentals and basics of sepsis management, but as we've got less than an hour, it won't be a comprehensive thing, but hopefully any questions, queries, or any points of debate people want to raise, I'm more than happy to discuss. So without further ado, we shall move on. So first thing, sort of key resources that are out there for people to access, and I would strongly encourage people to look at these. The Surviving Sepsis campaign, which is the international initiative around improving the management of sepsis, has been around for a number of years. The most recent iteration is from a few years back, and that's freely available with some useful little materials associated with it, and some of the presentation that I'm doing today draws from the Surviving Sepsis campaign. More recently, however, NICE updated their 2016 guidance a couple of weeks ago and published it. And that's been much anticipated for about the past year and a half. And it's about particularly the recognition, diagnosis, and early management of sepsis. So often the pre-ICU phase, but is still very relevant and important to us. So there will be quite a bit of discussion about that. The UK Sepsis Trust produces huge amounts of resources to support both the public and professionals around sepsis care, and have been very quick in producing resources that are linked to the new NICE guidance. So again, there is a link to their website with all the various resources that are available for that. I'm going to focus on adults. There are separate sort of sepsis pathways associated with both children of various ages and also in maternity, but for the sake of brevity, I'm going to just focus on adults today. So one thing I tend to always start with in this type of presentation is coming forward early on with, when we're in ICU, what do we go to in the cupboard for specific treatments targeted to manage sepsis particularly? And I produced a nice little list for you, and there it is. Nothing. Arguably, there is no real specific targeted treatment for sepsis that we have right now that massively influences our patients' outcome. And that's why particularly the early recognition and management, which does influence outcome phenomenally, is so very important, and what our role in that whole process is. So we should be very, very passionate and enthusiastic about making sure that patients are coming to us as soon as possible and treated as well as possible in that very early phase of recognition and early management, because that's what changes the game for our patients. That's what makes our life a lot easier, and that's what makes the conversations with patients' relatives a little bit easier too. So without further ado, we'll crack on. But there are treatments obviously in ICU, but there is no specific thing for sepsis at this point in time. Things have come and gone, but where we are right now, no. So main aims of the session: why is it important? The cardinal definitions of what we're talking about with sepsis. It's a term that's banded around all the time. It does have a very specific definition. There are also patients that are particularly vulnerable to sepsis and the risk factors associated. We will spend quite a bit of time talking about the initial recognition and management of sepsis as per new NICE guidance. We'll talk a bit about the nuts and bolts of ICU care of sepsis patients, and we'll talk about the complications of patients that have had sepsis when they leave our unit. And then after that, we can also talk, if you wish, about anything particular. Why is sepsis important? About a quarter of a million, a quarter of a million patients develop sepsis every year, and about 1/5 of those die. Not always are not always avoidable deaths. Most people will have things like cancer or heart disease or lung disease or something, and die with sepsis rather than of it. But it's thought that up to 15,000 of those 50,000 are preventable. The cost to the UK economy is about £16 billion, which, to quantify, is about 10% of the entire NHS budget. So that's the cost to the economy of all things, the cost of treating patients, the cost of losses to the workforce, etc., etc. The guy on the right is a guy called Tom Ray, who about 20 years ago developed Group A strep sepsis and lost all 4 limbs and half of his face due to a bout of very profound sepsis. He has become a massive sepsis advocate, and a film has been made about his life called Starfish, which you can, I'm sure you can look up and you can watch if you wish, but it emphasizes very clearly the sort of legacy that developing profound life-threatening sepsis has, and the immense physical and psychological impact that it can have on our patients. And then performance, particularly for the trust. So the CQC uses sepsis management in hospitals as a surrogate marker of the quality of acute care, and come down very hard on trusts where they see imperfections in that type of management. Similarly, NHS England are always looking for assurances around the quality of care for sepsis patients. Courts more and more, either in the coroner's court or possibly coming into criminal courts now, are becoming more and more savvy to issues related to inadequacies in the management of sepsis. And allied to that, really, and there's been notable many cases in the media, both the traditional media and in social media, where things go wrong, and it becomes a big story and has reputational issues for both the individuals and the organisations involved. So it is a big deal for us in intensive care. On a general intensive care unit, about a half of patients will either be admitted with sepsis or develop it while they're with us. So for us, it should be part of our core business. So where are we definitions? Well, it hasn't really changed very much, the headline definition of sepsis in the past 8 years. It's probably due to be updated very soon. But where we sit right now, sepsis is defined as the life-threatening organ dysfunction caused by a dysregulated host response to infection. And that was the International Sepsis 3 definition from 2016. And derivatives of this particular definition have then been taken forward by national organisations, and for us that's nice. What does that mean on the shop floor? Well, it's the coupling of 2 things that lead us to define a patient as having sepsis. So it can be, it is first of all, a clinical suspicion of infection, and that's an important statement to make. Suspicion of infection, not a confirmed microbiological diagnosis. It's a sort of amalgamation of clinical features, immediate investigations, vital signs, etc., to build a suspicion of an infection. And if that suspicion is moderate or high, then if you then have evidence of organ dysfunction, and around the world and in the UK, there are various markers that you can use as markers of organ dysfunction. SOFA score, Q-SOFA, which came out of the consensus definition in 2016. Red flags, which we've been using in UHL for probably the last 6 or 7 years. And red flags are essentially those parameters within news where a single parameter flags as 3 points or red. So, for example, a blood pressure less than 90 systolic, a heart rate over 130, or say a respiratory rate over 25. All of those are red flags that indicate organ dysfunction, and when coupled with suspicion of infection, lead you to suspecting sepsis. SIRS was part of the old sepsis 2 definition, is kind of defunct now, and more recently, the Royal College of Physicians in the past 2 or 3 years have suggested an aggregate NEWS 2 score of 5 or more as a possible marker of organ dysfunction to use to identify sepsis. So those two, infection plus organ dysfunction, you would then be thinking about someone with sepsis. That cohort of patients have a risk of death of somewhere between 10 and 20%. So this is not inconsiderable, really, in terms of risks for our patients. So that's where we are, and that really kind of hasn't changed with the new NICE guidance, as you'll see. It's still the same in terms of an organ dysfunction plus suspicion of infection. Now, septic shock, it was also addressed in the consensus definition in 2016, and that too is the same clinical suspicion of infection alongside markers of hypoperfusion after initial fluid resuscitation, which should be around 30 mils per kg. If there is a raised lactate above 2 and a mean arterial pressure of less than 65, or as is a surrogate, a systolic of less than 90, and a need for vasopressors to provide adequate organ perfusion to maintain, say, urine output or cerebral perfusion, then if all of those criteria, the lactate, the blood pressure, and the need for vasopressors, alongside a suspicion of infection, then you can say the patient has septic shock. This cohort has a much higher mortality, approaching 50%. So these are a particularly high-risk group of individual patients, and ones that we should be particularly mindful of identifying early. So I mentioned risk factors. Certain patients are at particular risk, and this is a list that comes from NICE. Diabetes is a really important one. If you go to the microbiology lab and pull out all the positive blood cultures, 1/3 of those positive blood cultures the patients will be diabetic. So diabetes is a huge issue for patients developing sepsis. And as Leicester has got a big diabetic population, I think we are particularly highly represented in this area. And then it's a little bit like a walk around an acute medical unit. So frailty, anyone that's immunocompromised either by things like specific hematological problems or drugs like chemotherapy or steroids, but particularly excess alcohol use. We see a lot of that LRI, patients immunocompromised by lots of alcohol. Then recent severe illnesses, trauma and burns, that kind of thing is fairly obvious. Recent surgery, pregnancy or recently pregnant, and children under 1, they're all specific increased risk factors for developing sepsis. So I'd like everyone to put their cameras on if you can. What I'm going to do is go through this clinical scenario, and then I've got a pop quiz for you about what we might do with this patient. So this is a fairly typical presentation to the emergency department. A 60-year-old female presents the ED with breathlessness and a productive cough, few days of flu-like illness, has got a respiratory rate of 26, a SATs at 89% on air, it's tachycardia, sinus tachycardia of 120, blood pressure is normal, has got a temperature of 38.1 and is alert. On examination, she's got some signs in her chest with good air entry, but lots of noises, crackles and wheezes bilaterally. In her past history, she's a diabetic with COPD and normally takes bronchodilators and metformin. So what would you do? There are 2 options for this. So option A is to say, right, well, this patient has got an EWS of 8. They have 2 red flags. in the respiratory rate and the saturations. They are have a raised temperature and clinical signs of a chest infection or pneumonia. Therefore, they meet the sepsis criteria, and we should start the sepsis 6 immediately and get some antibiotics into this patient within an hour. That is option A. And then we have option B, which is to just say, hang on a minute, let's just take stock for a second. Let's do a full clinical assessment, maybe get some extra history from the family, look through their previous attendances, clinic letters, etc., get some immediate bloods and a chest x-ray off, and possibly discuss with someone more senior, but with an aim to get some antibiotics in, hopefully within 3 hours. So they're the therapeutic options that I'd like you to consider. So with a show of hands, please, who would go for option A? Okay, so we got 1, 2, 3 in LRI. There's a hand up, so 5. We've got 6, I can see 6 hands there. Okay, who's going to go for option B? Oh, I think, yeah, Kaz Sampson. Yeah, thank you. Anyone else? Looks like you're on your own. Yeah, so it's 6-1. Okay. So what I would say is that you are both right and both wrong. So if we're going by existing guidance, you probably say that A is correct. But what you're going to see from now on is that maybe that what I'm about to show you about the new NICE guidance is that actually we may be moving more towards option B. So with all the big sepsis initiatives that have been going on over the past 10 years or so, there's been a huge escalation in aggressive treatment for patients with infections. And this has been a good thing in many ways. The mortality from sepsis has been dropping quite significantly over the past 10-20 years, and at least in part that's due to the improved management of these patients and prompter recognition and management. The downside of that is that there's been a massive overuse of antibiotics, as I'm sure you're all aware, and the huge emergence of antimicrobial resistance in the form of, things like CRO, and other extended spectrum resistant bugs, and this has become increasingly concerning for the healthcare organizations all over the world, to the point where the Academy of Medical Royal Colleges in the UK about a year and a half ago came up with a more stratified approach to patients with sepsis, and not adopt a sort of binary approach of they trigger the sepsis pathway, therefore give antibiotics as soon as possible, don't mess about. So there's been an advocacy of a much more stratified approach, looking to see actually if there are other factors that might be causing someone to trigger, say, a red flag, or maybe we could spend a bit more time finding out if a patient actually has an infection in the first place. So with that, this is from the UK Sepsis Trust, and this is a neat distillation of what the new NICE guidance says. NICE guidance document, which I've shared with you as the link, is 100 pages long. Now, most of that actually is addressing sepsis management in various stages of children, in maternity, and so on and so on. So the bit that actually is about adults in hospital is only about 10 or 15 pages. Still maybe a big read, but a little bit more digestible than it looks at the outset. What the UK Sepsis Trust have done is distilled that down into a simplified pathway. And I'm going to sort of illustrate now the big differences to what we do currently. So what we do currently is measure someone's news score, and if it hits a certain level, if there's a red flag, then that immediately triggers the nurse on the ward to make a decision as to whether or not the patient has a new infection. And if that is yes, then a sepsis alert is triggered, and someone will then have to review the patient and start to think about whether or not to do the sepsis 6. What this new guidance suggests is that, first of all, that first clinical responder, the nurse on the ward or in an ED or a paramedic or whoever, has to think a bit more broadly. So yes, it might be on the basis of a news score. It might be because of care or relative concern, which is something that's very pertinent in the news recently. Recent chemotherapy or a risk of neutropenia, that is something that has been bubbling around for a while. Patient looks unwell from the end of the bed, that's common sense. They may have had a serum lactate measured, or other markers of organ dysfunction might be there, such as an AKI. So that, or the general assessment gives clinical cause for concern. So any one of those should trigger a formal review, and that formal review will be by the first responding junior doctor of FY2 grade or above. And I'm going to say now is that there is going to be a lot of onus on this FY2 plus. So if you're an FY2 or a CT who works in ED, acute medicine, or somewhere on the wards, you will be in the near future expected to do what I'm about to say. And a lot of it's common sense, but a lot of it, you know, may not necessarily come straight to mind. So the FY2 will have to do a comprehensive risk assessment of the patient, measure their lactate and calculate and break down the news 2 score. And interpret that based on the context of the patient's own medical history, medications, and the response to treatment. Now, if they don't really have much in the way of comorbidities and they're scoring news 7 or more, then it's a no-brainer. They need to go on and have the sepsis 6 as soon as possible. If, however, the news score is slightly lower than that, but they have something else going on, like a score of 3 in one parameter that is not part of their chronic illness, or they're mottled or cyanotic, or deteriorated maybe since you last assessed them, or you've started them on oxygen and their oxygen requirements going up, or some other deterioration despite treatment, or they've got a high lactate, or they've got an AKI, and their news is 5 or 6, then they need the sepsis 6 starting immediately as well. If they don't have any of those things, then you can maybe think about whether they've got a moderate risk. So in other words, if they've got a news 5 or 6 standalone, which can't be explained by their chronic medical history, say for example that they've got COPD and have normally got SATs of 90 and are normally quite breathless with a respiratory rate of 25, 26, or you know, they're normally semi-conscious because of a chronic brain injury. You know, all of those sorts of things have to be taken into account. But if they've got a news of 5 or 6, then you treat them as moderate risk and just slow down a little bit. So send a series of bloods, discuss with a senior, and maybe look for further evidence to support a diagnosis, and aim to give antibiotics within 3 hours if you need to. So you know, there's a lot, I think, to take on board here, and I'm just sort of summarizing what the FY2 plus response would need to be. First off, they'll need to confirm whether or not there's a suspicion of infection. You know, what are the clinical features? Are there microbiological or hematological markers, raised white count, CRP? Is there flicking fevers, and so on and so forth? Interpret and know how to break down a news 2 score and link that to the patient's chronic illness. Do and interpret a lactate and look at their U's and E's. Balance the impact of any comorbidities that patients might be carrying or frailty. consider the response to treatment dynamically and how they were last time you saw them. Has that fluid you given improved the blood pressure as you expected, or has it not? Look for skin changes, particularly things like mottling and cyanosis and weird rashes. And then go on and think about choosing the right antibiotic if you're going to give one. And this will probably involve looking at the Trust's antimicrobial policy. So there's quite a lot that is expected of our junior medical staff to do if a patient gets alerted as being septic or possibly being septic. And I'm going to say that I would imagine there'll be a lot of these alerts that will come through on any particular day, and a lot of work will be done in this area. Just a reminder of what the Sepsis 6 shows, and recent years it has changed slightly with the addition of informing a senior clinician. So that is number one on the list. So if you assess someone you think that they are high risk for sepsis, or in other words, NUSA 7 or more, etc., then one of the first things that you should do is notify someone at ST3 level or above to review the patient, okay, so that they can seek alternative diagnosis and maybe de-escalate care if necessary. Oxygen as required, taking into account someone that may have chronic lung disease. Bloods, including blood cultures. Now, blood cultures, I've noticed in recent months, are increasingly omitted in patients presenting with life-threatening sepsis, particularly to the emergency department. Please, if you are reviewing somebody that might well be septic, please get a blood culture off before any broad-spectrum antibiotics are given. It makes such a difference in a couple of days down the line as to what diagnosis the patient may or may not have. Give IV antibiotics. So essentially going with local policy. When do we give broad spectrum agents like meropenem, tazocin? Tazocin you would use for neutropenic sepsis as first line therapy. A broad spectrum agent like meropenem now will probably be reserved when you're not really sure on the source of the infection, say whether it's above or below the diaphragm, for example, and in situations where someone has got septic shock, where you've got to be as sure as you can be that you're giving an effective antibiotic straight off the bat. Okay. Source control also, so initiating a process by which you seek out and confirm where the source of infection is, and that may well be requesting complex imaging like CT scans, etc., and involving potentially surgeons to come and take over the patient's care. They're really important to initiate within that first hour. IV fluids, and again that's dependent on whether the patient's showing signs of hypoperfusion. So certainly boluses of 500 ml stat in somebody that has a high lactate or a low blood pressure, and to repeat if necessary. Senior review after that is important to rule out causes of hypotension that are not due to hypovolemia or sepsis. And monitoring, that's really important, particularly urine output, continuous news, and doing news every 30 minutes when someone's has got high risk sepsis. So that's the Sepsis 6. I say it's changed slightly over the years, but that is what you should be aiming to do in somebody who has got high risk of sepsis. As I mentioned, septic shock are a particularly high risk group of patients with a mortality of around 50%. In these patients, the Sepsis 6 has got to be done promptly. As I mentioned, you'll be giving a broad spectrum IV antibiotic such as meropenem. The Surviving Sepsis campaign suggests it should be at least 2 separate agents, and we'll often be doing that. So you certainly consider covering every possible infective diagnosis from the start, because time is the absolute enemy in patients with septic shock. And if we don't deliver effective antibiotics immediately, then it will massively detriment the patient's morbidity, mortality risk. We must involve someone senior, ideally a consultant, right from the off. And if the patient is going to be for escalation, these patients should be considered and taken to intensive care. Remember, they've got about a 50% mortality. There is no place really for patients with septic shock going anywhere other than intensive care or theatres for source control. Early vasopresses is a bit of a moot subject at the moment. The Surviving Sepsis campaign gives a weak recommendation to give early vasopressors, particularly in the form of peripheral norepinephrine, and that is in place in the ED in UHL. So if we do come across a patient in ED who's hypotensive after initial fluid therapy and is coming to ITU, we really should try to stabilize them and get their blood pressure up above 90, ideally 100 systolic before they leave the department. We know from previous experience that logistically what happens is that these patients can get large volumes of fluid and can wait a long time for a central line to go in to start on vasopressors, during which time they are, horribly underperfused, and their risk of renal dysfunction and mortality will go up. So pragmatically, in UHL, we would advocate the use of peripheral norepinephrine in ED to stabilise their blood pressure before transfer to ITU or into theatres. And alongside that source control, as you'll hear in a minute, the Royal College of Surgeons says that anyone with septic shock should have source control initiated within 3 hours. So common pitfalls with sepsis, particularly in the recognition and management phase. What we see with previous audit data is that new confusion, which is a massive red flag, is often missed and needs to be specifically acknowledged and looked for in patients presenting possibly with sepsis. Hypoxic patients that are do not have hypercapnic respiratory failure can inappropriately sometimes be put onto the hypercapnic model to reduce their EWS by 3. We've seen that a few times. It helps reduce someone's overall NEWS score, and for whatever reason that can be done, but it's not appropriate for patients that are acutely hypoxic. A high patient temperature is not essential for the diagnosis of sepsis, okay, or infection. So it's just one facet, and you shouldn't rule out a normal temperature. Okay. Something we saw a lot over COVID actually was patients getting very, very sick with not much change in their NEWS 2 score, but you could tell by the amount of oxygen requirement rocketing that the patients were obviously deteriorating. And that's the point that's been raised, I think, in the NICE guidance about reviewing the response to treatment. That somebody on 70% oxygen will have the same NEWS score as someone on 24% oxygen, although they're obviously far, far sicker. Always check your patients for mottling. I mean, this is severe mottling, almost going on to purpuriforminans, but that's a very poor prognostic sign, and it will immediately bump someone up into a high-risk category if it's present, and that will mean that they need to be treated immediately. So I mentioned about source control, what the College of Surgeons says: septic shock, straight to theatre. Sepsis, they should really be in theatre within 6 hours, if possible. Ideally, no more than 12 hours is what the is what the UK Sepsis Trust will say. What have you got around the trust to help you? Several things. The first one is DART. DART are very, very accustomed to managing and supporting ward areas and in the emergency department for managing patients with sepsis, and they can help deliver the sepsis 6. They can help coordinate things like imaging and further referrals. They can also support the administration of peripheral noradrenaline in ED, and obviously can help liaise with the intensive care unit. Sepsis boxes, top left there, they are present in every resus trolley in every ward under trust, and are there to help deliver the sepsis 6 to patients in ward environments. They're hardly ever used, which is a bit of a disappointment, but they will speed up the treatment for patients in with sepsis. Now, nerve center I've put there. Currently nerve center electronic alerts are there, which raise up high risk patients and alert staff and DART and junior medical staff to possibility of sepsis in ward environments. It's not currently live in the ED, but it may be so in the not too distant future. That alerting system, it will have to change significantly with the new sepsis guidance that's come from NICE. So what about what we do in the ICU? And I'm going to keep this fairly brief, but I guess the challenges that we have are patients with septic shock and those that develop multi-organ dysfunction or multi-organ failure, and that can be a combination of any of ARDS, cardiomyopathy, renal failure, coagulation problems, immune failure, bone marrow failure, liver, gut failure, skin falling off, and a septic encephalopathy. And I'm sure that list isn't comprehensive, but they are the challenges that we face with these patients in ICU. Obviously, antimicrobial therapy is the cornerstone of treating these patients, and this is leafed. Sorry, there's a lot of text on this slide, but this is taken directly from the Surviving Sepsis campaign. And what I would say first and foremost is that we must have a strong, positive working relationship with both our microbiologists and unit pharmacists, who will help us enormously in this. So yes, we should, with patients coming in with septic shock, obviously be giving empiric broad spectrum agents from the outset, and then use our various results and our microbiologists to try to narrow with pathogen identification and sensitivities down to a more targeted antimicrobial regime. Then obviously with working with pharmacists to make sure that we're giving the dosing strategies correctly, and the classic one obviously is patients with renal failure and then go onto a filter, making sure that the dosing is right, vancomycin administration, getting that right, is a piece of work that we have to pay attention to. As I mentioned, the Surviving Sepsis campaign recommends at least 2 agents for the management of patients with septic shock, notwithstanding that we should narrow our spectrum as soon as we reasonably can. We shouldn't be giving combination therapies for patients with neutropenic sepsis unless we have to, and de-escalating as soon as we can. We shouldn't be giving antibiotics for more than 7 to 10 days unless there is some kind of undrained foci or some deep-seated staphylococcal infection or endocarditis, something like that. Very short courses of no more than 3 to 5 days are possibly relevant in patients where there's rapid clinical resolution, and we should be reviewing our antibiotics every single day, which I think we do. We use procalcitonin, I think, more and more these days, particularly around whether we think there is an evolving unchecked septic process going on in a complex patient, or maybe to guide de-escalation decision making. I think what the Surviving Sepsis campaign says currently is that we shouldn't use it as should not use it in that first presentation diagnostic, has the patient got sepsis or not. I don't think there is enough evidence to support that claim at the moment. Fluid, well, I won't go too much into this, but it's fundamentally based on a dynamic process of things like passive leg raising, and you may have used other more complex things, but fluid resuscitating with crystalloid, and if you're giving lots of it, you can have the option to add in some albumin. We should not be using starches or gelatins. I'll move on from that. Vasopressors, noradrenaline's first line, vasopressin the second line, plus or minus adrenaline. Don't use dopamine. Dobutamine, very now and again. I don't think we've used it at the Royal for a long time. And we should titrate to perfusion. We may well use things like reducing serum lactate levels, for example, as a marker of resuscitation, etc. You should always put an arterial line. I think that's obvious. Okay. Other adjuncts, obviously, we still use steroids, and there's still support for that, giving 200 milligrams a day often in divided doses in patients on large doses of vasopressors. Transfusing at 70, not using IVIG. No recommendation around blood purification techniques. And there's no real support for anticoagulants at the moment. Ventilation, a lot of patients get ARDS, so I'm not going to go into this too much, but essentially low tidal volume, lung protective strategies are the way forward. Do not use high frequency oscillation. Because we've got Glenfield, I better say ECMO is an option. Don't use neuromuscular blockers. No recommendations about NIV in these patients. I think it can be detrimental. Be a bit more conservative with fluid in these patients. Beta-2 agonists don't have a role. Don't use PA catheters, and flat hug your patients every day. Renal support, you can use intermittent or continuous support depending on how stable the patients are. Don't just use creatinine and urea as the decision making. I think it's much more about fluid balance, potassium, acid base, all that, particularly on an individualized patient basis. Only use bicarb in desperation when the patient's got a very low pH. Complications of sepsis. So just finishing up now, really. Death, well, the death rate from sepsis to patients into ITU overall sort of fluctuates between 15 and 30%. As I said earlier, it has dropped quite a bit over the past 20 years. For patients with septic shock, it's 40 to 50%. 20 years ago, it was 70, 80%. Long-term renal replacement in patients is about 5%. Quite a few patients lose their fingers or hands or limbs, and that's of the order of 5 to 10%. Unquantified, really, septic encephalopathy, long-term cognitive impairment. There's a growing sense that this is a major issue, and linked to that, the post-sepsis syndrome, which is a bit like long COVID, in that patients have fatigue, exercise intolerance, susceptibility to further infections, and long-term sort of brain fog. And then anyone, I guess, that's been through the ICU clinic will know that I think post-traumatic stress disorder is a particularly big problem for these types of patients. Not to mention that the last one there, if in patients that have had significant lung injury, then long-term respiratory impairment also can be a problem for them, limiting their functional state. Okay, that was a very quick whistle to stop tour, but I'm more than happy to take questions. Hi, Mike.
Hi, John. When's the integration with Nerve Centre coming to make that decision-making process with the FY nice and easy? Because it sounds like you need a bit of chat GPT involvement with that first decision-making to decide whether to give antibiotics or not.
You're right. I think until there's an AI co-pilot sat in a junior doctor's pocket, this isn't going to work. We've had some embryonic conversations about this. This is still very early, but I can't see an all singing, all dancing nerve centre solution as we stand to this new pathway. It's far too complicated. But that said, you know, technology is marching on, and I think Gang Zhu, our deputy medical director, has said that we still have a working partnership in development with Nerve Centre. So watch this space. I think I don't know the answer to that at the moment, but is Chris Hebbs in the corner telling you something separate there, Mike?
No, it's just I've been asked a clinical question.
Oh, I see. Right. Yeah. So yeah, you're right. I think this is going to be an extremely challenging period going forward. I think we're substituting one problem for another with this new guidance. And I worry that we are going to be putting an enormous burden on the shoulders of our most junior medical staff. Zoe.
Hey, John. You said don't give IVIG. We're still giving it for
Oh yeah,
invasive group A strep type patients.
We do, yeah, and I think that's from the surviving. I think that's a sort of blanket thing rather than specific for targeted things.
Okay.
So I agree with you. Yeah, thank you. Thanks for clarifying that.
That's all right.
Well, good luck everybody for the future of sepsis care on the wards, and yeah.
Yeah, thanks for that.
You know, there's a lot of concern about this, and we will come up with something, I'm sure.
Yeah, I bet. Fine. Thank you very much for doing that, John. It's helpful because it's a lot of it, and it's all quite new.
Yeah.
Right, so I'm going to do Journal Club today on thrombolytics and cardiac arrest from PE. So just to give you a bit of background, so the ALS, so on the left is the kind of special circumstances guidelines part of treatment of PE. And on the right is a thrombolysis therapy in PE and the UHL guidance. So cardiac arrest from acute PE is the most serious clinical presentation of venous thromboembolism, in most cases originating from a DVT, and the reported incidence of cardiac arrest caused by that is about 2 to 7% or thereabouts of all out of hospital cardiac arrests, and about 5 or 6% of in-hospital cardiac arrests, and that's likely to be an underestimation. So it's an important issue, and overall survival is low. So specific treatments for cardiac arrest resulting from PE include administrating fibrinolytics such as alteplase or streptokinase, urokinase. Those are the ones that are in the UHL
Hi,
guidance.
Rikesh. Sorry, I think we could see the slides, but
so
we cannot see it anymore.
May also include, as ALS guidance says, surgical embolectomy or percutaneous mechanical thrombectomy as well. So I've just kind of put that in there for kind of context. And specifically thrombolytic agents such as alteplase, they work by activating plasminogen to form plasmin, resulting in accelerated basically breakdown of that clot that's formed. So the current ALS recommendations are to consider if PE is a suspected cause of the cardiac arrest to administer thrombolytic drugs. So I just thought I'd add that before I go on to talk about the article, just for context. And just so it makes a bit more sense later. So UHL recommend the preferred drug to give in that scenario would be alteplase. If cardiac arrest is imminent, it suggests a 50 milligram bolus. But there are weight based dosing outside of that, which is what the guideline says. So the key points, this is kind of just summarizing what the article said. So in the US, there's more than 365,000 out of hospital cardiac arrests. In the
Excuse
UK, it's
me?
about
Can you hear
30,000.
us? We can't see your
And
slides.
similarly, about
Hello?
more than 90% of those are fatal. I've already talked about.
You
how
can't
much
hear
is
us. I've sent a
linked to
message.
in practice, diagnosing PE during the actual resuscitation is really difficult, as we all know. And for a long time, IV thrombolytics have been administered due to suspected or confirmed PE. So yeah, we've been giving it for a while, and the rationale for that really is mainly expert opinion on the theoretical benefit, and mainly from benefit in patients with massive PE with a pulse, as opposed to in the context of cardiac arrest. And ACLS, the American Heart Association, and ILCOR, which is the international kind of consensus recommendations, they all back systemic thrombolysis in cardiac arrest, but actually there's very little evidence to support or refute the effectiveness of just giving it in suspected but unconfirmed PE. The newer guidelines from the American Heart Association, as well as the ALS guidelines, as I said before, do recommend it in cardiac arrest due to suspected PE, but they do acknowledge that it's a big knowledge gap that needs more research. So the paper that I'm talking about here reviews the current evidence behind its use in suspected or confirmed PE, and it actually is quite good in my opinion, because it talks about stuff like survival to hospital discharge and neurologically intact survival and bleeding complications. So I think it's quite good because it's what we care about. So what did this paper find in terms of the headline things? So it included 13 studies with a total of 803 patients in the review. Most of the studies were single-armed and retrospective. The dose that was given was variable, though. The agent that was given was variable, and the dose was heterogeneous as well. So that's something to bear in mind. So the key findings of this were, among those with control groups, thrombolysis was associated with higher rates of ROSC, with an odds ratio of 2.5, but didn't show any difference in survival to hospital discharge or bleeding complications. So they were the key findings. So use of thrombolytics in cardiac arrest due to confirmed or presumed PE is associated with increased ROSC, but actually no benefit in terms of hospital discharge or change in bleeding complications. So how did the systematic review go through all of the studies? So they used PRISMA guidelines. They did a PubMed search, and they included, in my opinion, relevant keywords: TPA, PE, cardiac arrest. But they were limited to studies in English or those with an available English translation. The way that they screened through all the studies is 2 reviewers independently screened them, and they did monitor inter-rater reliability. They included randomized controlled trials, prospective and retrospective cohort studies, and they excluded case reports and case series, that lower grade evidence. They included in-hospital cardiac arrest and out-of-hospital cardiac arrest populations, and they did perform a bias assessment. And the results, just to go in slightly more detail, and I've included the table on the right. So their initial literature research yielded 2,800 studies, and from this they narrowed it down to 28 and then 13 relevant studies, and out of those 13 studies that they ended up whittling down to, 12 were retrospective and 1 was prospective. And as I said before, it was about 800 patients. The thrombolytic of choice included alteplase in at least 10 studies, tenecteplase in 4, and then streptokinase and monteplase in 1 each, and then 2 studies didn't specify. If alteplase was used, The most common was a single 50 or 100 milligram bolus, but sometimes it was a weight-based or bolus followed by an infusion. And out of 13 studies, all studies included the primary or secondary outcome of ROSC, and 11 included the secondary outcome of survival to hospital discharge. So focusing on the primary outcome, so among non-randomized studies, which were multi-armed and contained a comparator group of patients who didn't receive thrombolytics, only one study, about 40 patients, actually found a difference in ROSC that favoured the intervention group, and the other 5 that measured ROSC found no difference at all. But despite that, the actual meta-analysis found that ROSC was more common in the thrombolytic groups than control. And then talking about secondary outcomes, survival to hospital discharge was measured in 5 studies, but only differed in 1. And when they pooled them together, there wasn't any difference in survival to hospital discharge, as I said before. And only 7 out of the 13 studies included major bleeding complications as an outcome. And they commented that in the meta-analysis, there was a trend towards an increased number of major bleeding events in the thrombolysis group, but they didn't find that to be statistically significant. And only 2 of the studies included neurologically intact survival, but neither of those found a difference. When I was reading through it, so the most common bleeding complication described was abdominal bleeding, such as perirenal or liver hematoma or rupture, and the next most common was central line associated, and much less common were intracranial and intrathoracic. And they commented in the script that there's no evidence suggested increased mortality with bleeding adverse events in PE with hemodynamic collapse, which is quite different than the generally accepted risks of major intracranial bleed of about 6% when using probably quite similar doses of thrombolytics with stroke. And I think that's well, they think that's due to the lack of structural intracranial pathology that's there. So I've just put this there for those that haven't seen the paper. That's showing the ROSC. So you can see that there, and that's the top study, the Kirksian paper, that did show the difference. So the results, they did a bias assessment, and they determined that there was moderate to high for most of the studies bias, and they attributed that to non-consecutive or poorly described enrollment methods, difference in patient characteristics, and the retrospective nature of collection. And one study was sponsored by the manufacturer, so that was a big concern that they also acknowledged. Other limitations, so the studies included were quite heterogeneous in methods and outcome of interest. I said that, and the agent that was used, how it was administered, and the fact that neurologically intact survival was absent for more than half of the studies. The majority of individual studies included patients who had suspected and not actually confirmed PE. So they acknowledge that, and that would probably skew away from a positive treatment effect. However, including suspected PE associated cardiac arrests are probably more relevant to us as treatment clinicians than just included confirmed cases, because in the majority of cardiac arrests, there isn't a definitive etiology of the arrest available when you're actually beginning the resuscitation. So I think that was fair. So I just did a quick CASP review of this paper. So firstly, did it address a clearly focused question? Well, I thought yes. The population, in the US, it's probably quite similar. I haven't personally looked at the individual studies, but I think looking at it crudely, it's a similar population, and the outcome measures I thought were appropriate. Did they look for the right time of papers? I said somewhat or no. They only looked at English papers or those that were available with translation, and they did limit it to publicly available data. They didn't reach out to authors for additional information. And something which which struck me was how many studies were excluded. So they identified, like I said, 2,800 studies, but they didn't really discuss why there were so many that they couldn't include. That was a bit of a red flag, really. But did they do enough to assess the quality of the included studies? I think yes. So they had independent reviewers, they commented on reliability of the raters, but they didn't go into a huge amount of detail about the quality of studies, apart from commenting on bias. If the results of the review have been combined, was it reasonable? I think so. The results of the studies are clearly displayed, but in my opinion, I think that they are quite dissimilar, the results. What's the overall results? So there's limited evidence supporting the use of thrombolysis in cardiac arrest from presumed or confirmed PE. And they said that the observational nature of the studies, as well as their bias, they need prospective randomized controlled trials, really. But at the end of the paper, they recommended continuing the existing consensus guidelines, which support the use of thrombolytics for this indication. How precise were the results? I mean, the confidence intervals were pretty wide, to be honest. So I didn't think that they were that precise. Can they be applied to our local population? Yeah, I don't think that the patients that were covered by the review would be that different for me to cause concern. So I think it can be applied to our population too. And were all important outcomes considered? Yeah, for me, ROSC is important, but actually survival to discharge, neurologically intact survival is important, and bleeding complications. Are benefits worth the harms and costs? They didn't talk about it in the review at all. But yeah, I think if there's a strong suspicion, it's probably worth it. In my own opinion, I think for me, the evidence isn't there. They need to do randomized control trials, yes, but there weren't any significant bleeding complications. So I think it is difficult during arrest, yeah, but if you've got a strong suspicion, follow the guidelines, which is give IV thrombolytics and continue your resuscitation for 45 to 60 minutes, and it's worth the £432 that the BNF says it is to administer 50 milligrams of alteplase. So that was it. Thanks very much.
No, fair enough. I'll just set the feedback slide up, so if people can do that for John and Rikesh. Did anybody have any questions for Rikesh? Nobody's going to say anything. Have you ever been to a cardiac arrest where you've given thrombolysis?
I've been to one person. Sorry, can you hear us? Yes.
Yeah.
Yeah, I've been to one. I'd say it was quite a while ago, and we used the Lucas device to deliver CPR for a long time. The outcome wasn't positive, but I mean,
It goes on for a very long time. Yeah, so getting the Lucas is actually a good idea, because otherwise people just get exhausted.
I think it's a really difficult one to try on, but
yeah, I think it probably is, to be honest. You might get ROSC. I don't know whether it would, if you've been doing CPR for an hour. I'm not sure they're going to have that good an outcome, to be honest. So it's going to be really difficult to study.
What do you think about? Did you read this particular paper? What were your thoughts on it?
I didn't read it properly. I kind of skimmed it. Did I have any thoughts? I thought it was probably, like you said, it's going to be a really difficult thing to study and find out whether you get a meaningful outcome from it. But it's probably the only thing that we've got if that happens to try and make it better. So it's probably worth a try. If you think it is a PE or have a confirmed, it's more reassuring if you have a confirmed PE that then gets worse.
Yeah.
Yeah. Well, thank you for doing that. Much appreciated. I will leave that slide up for a bit if people can, if anybody hasn't done it. But have a lovely weekend. Hope it's all right.
Thanks.
Thanks very much.